So my company is Workit Health, and we provide digital addiction care online. And I'm one of the founders of the company, and we are about 5.5 years old. So I really enjoyed so many of my co-presenters' facts and figures about how their companies have been changed by COVID. We know in the opioid space and in the addiction care space more broadly that there have been enormous problems associated with increases in addiction during COVID. Now that's normal during any epidemic, any crisis. I did a lot of work in New Orleans after Katrina, and meetings were gone. Self-care methods that people used in order to do fellowship with one another in late stage recovery were gone. It's no different with addiction. We're just coming off the tail end of a lot of national focus on the 70,000 individuals who died in 2017 from opioids. And this is by and large a very substantial Medicaid problem. I think James made a really good point earlier in saying that Medicaid has been leading in a lot of ways in the treatment of behavioral health, sometimes with better coverage than commercial plans, which is something we've never seen before in this country. And Medicaid directors are crucial stakeholders in the opioid epidemic. We know that at least, and these numbers are just what we saw pre-COVID. It's changed dramatically in that 40 million Americans just switched to Medicaid care. So very soon, the numbers that you'll see on the screen here about the number of individuals covered by Med are going to be significantly higher. So we know 12% of Medicaid beneficiaries have a substance use disorder, which is much higher than the US average. Specifically, we focus at Workit Health on opioid use disorder. And we know that 38% of individuals with opioid use disorder are covered by Medicaid, which is more than double the US average. And that it's a huge spend within Medicaid systems. 28% of all SUD spend comes from those systems. And it's going to increase dramatically over the course of this epidemic. And basically these dual epidemics which we are experiencing. So we're basically continue to be in a state of systemic failure. And I like to share this slide because I started my company because I saw a lot of individuals pass away from addiction from many walks of life and with many different social determinants of health that drove them to lose their lives. And we are finding that as we increasingly have a complex world within COVID, this situation is getting worse. Addiction is driven by social isolation. It's driven by stigma. It's driven by access to care issues that make treatment in the space very difficult. And it's no different within the Medicaid population where it's dramatically impacted by other chronic conditions that people are struggling with on a medical basis. So what do we do? So as a patient myself, as someone who started this company with a lens on all of the broken spaces that we had within our addiction care system, we wanted to make a program that was immediate access oriented. So what we do is offer on-demand addiction treatment that is accessible and follows the gold standard of care. So that looks like, first and foremost, we have an app that patients use to receive a full spectrum of telemedicine services for addictive behaviors, everything from opioid use disorder to alcohol use disorder, as well as all of the co-occurring addictions that underlie primary addictions, such as sex and love addiction, gambling use disorder, increasingly internet addiction, and other forms of process addictions that are comorbid oftentimes with addictive behaviors. In our platform, patients are able to directly book appointments with a medical care team and a psychosocial support team. All of the elements that you would have in an intensive outpatient program are available on the Workit platform. We're actually licensed as an intensive outpatient program in several states. And so it's the equivalent amount of care that you would receive for a patient who needs services that are where hospitalization is not required. What our journey looks like, we take a very strong consumer-facing approach. As individuals who've been through the condition ourselves, we know that healthcare plans, community social services have often taken very traditional approaches to making care available to individuals with substance use disorders that are mismatched to how individuals look for care. Oftentimes, individuals in the substance use community are looking for care from friends who've gotten sober, from online blogs and searches where they're finding information about what the process might be like. Increasingly, individuals, especially who are 18 to 29, are taking this route. And we know that finding members where they are and making the situation safe to access care is key to having an addiction services system that will work in the future. So we either have patients come to us via online search, organically, or through referral networks. And those are both traditional referral networks as well as increasingly digital connections, such as Quartet, our former speaker we work with, as well as many of the other digital health providers that work in care coordination with healthcare plans refer directly into us, and we refer into them. Increasingly, we're finding that patients that like telemedicine services or are socially isolated benefit from other telemedicine services. And so it's exciting to start to see that full ecosystem of telemedicine services become available to people. And then once we engage individuals, we provide them with full stack wraparound treatment for substance use disorders. So because of all the regulatory shifts that we talked about at the beginning of this event, individuals are able to receive and never have been able to receive before, but all of our services directly through digital means. So they sign up online directly through a self-led sign up, or they can call us. I agree with James's comments that telephonic access is an incredibly important part of telemedicine access, especially in the behavioral health space, and that it's important to meet members where they are. So while patients can come to us through the app, they can also call us. And then we take a medication first approach. Within the addiction landscape, medical components have largely been absent from the scene for the past 100 years, where we've focused by and large on community-based supports and volunteer organizations to provide support in an ongoing way for patients after they get sober. But we have lacked the psychiatric integration and the really important medical components of medication-assisted treatment that patients need right at the beginning. So we do that first and foremost, and then we layer on top of that continued online treatment, ongoing cognitive behavioral therapy delivered through digital therapeutics and courses that are in the platform directly, the ability to text with a collaborative care team anytime, anywhere, both the medical professionals as well as the individuals who are counseling them, both group and individual, and then weekly appointments and drug testing so that we can medically monitor patients directly in the platform to ensure that they are both compliant with their medication protocols, but also not taking other medications that are harmful. Always bearing in mind that harm reduction oriented approaches are incredibly important. Most individuals seeking substance use treatment are not seeking treatment because they have been court ordered into treatment. And so it's very important to work with individuals and gradually reduce their substance use over time, particularly marijuana and other drugs that are now legal in many parts of the country. And then we provide weekly meetings for social support, which we've seen over the course of COVID, 40% higher attendance in that weekly component of the program, which is very interesting. And then our approach is really to stabilize patients in the first few months of care through high touch sessions with clinicians, as well as direct prescriptions and doing coordination with prescription drug management services, moving from there into a strengthening part of the program where we deliver a lower number of courses and individuals check in with their care team as needed. As someone in recovery, it's been long overdue to have more of a Planet Fitness model for treating patients with addiction, which we know is a lifelong condition that patients struggle with over the life course and is triggered often in moments of stress or in moments of serious change in life. The death of a loved one, a crisis such as COVID has led to individuals who are by and large stable needing to reconnect with the program and just get a pulse from their care team on what's going on with them, as well as get more support than they might need normally in the course of their everyday lives. And then once individuals have been with us for a couple of years, we really move to a very lightweight monitoring system where they get courses as needed and check in really as needed. So basically lifelong aftercare is provided in the program. And what our members are saying is that this is an extremely human-centered model, which was our hope in developing it. We knew that evidence-based modalities were out there for treating addiction, but that they weren't democratically available. And our patients are saying things like, in other places, you're treated almost like an object, where you talk and people hear the sound but don't listen or meet you where they are. And we really have been excited to see how members have responded to this model and found that the privacy and confidentiality of telehealth is incredibly valuable within the context of addiction care. More than a nice to have, it's a need to have for many of the individuals who've been too afraid to seek care at their federally qualified health center, at their local Alano club or group that provides face-to-face addiction support systems. And what we're finding, I thought I would share a mix of what we're finding clinically more broadly, as well as what we're finding in the context of COVID. Really in some of our markets, and there was a mention, I think at the beginning of the call, of the large degree of mortality that we're seeing within the Detroit metro system as a result of COVID. What we saw directly after COVID hit the area is really echoed throughout the country, but I thought I'd provide a lens to this group. We saw 80% of detoxes and intensive outpatients close overnight. We saw, so individuals go from having access to care through their FQHC or through their traditional means of using community-oriented social services, have absolutely nowhere to go. And this led within the Workit Health program to a massive increase of patients shifting to telemedicine. Had we not been available, there would have been a dramatic increase of overdoses in this region in particular. And so one of the major things that we've seen within COVID, because we've seen the ability to move to a full virtual substance use disorder model, is that there are some clear quantitative benefits and qualitative benefits in patient outcomes. So we're seeing that patients have actually lower blood pressure when they come into our first virtual visit than they would have coming into the clinic. Traditionally, we've done a hybrid model, which is still available in many states based on closure laws, but it has been something that we're measuring and sharing out, which is that patients have some white coat syndrome, especially associated with addiction care services. And we're seeing patients more comfortable in their homes, more willing to make the leap into the recovery process, which is something we didn't expect and has been exciting. As I mentioned, we're also seeing a lot more members attend group therapy than we saw before the epidemic. And then increasing attendance. So patients come to us, make their first appointment more frequently. And we think within our Medicaid book of business that this is largely because of other social determinants of health. So patients don't have to worry about transportation, calling an Uber for health, or getting a set of other services that will get them to our first visit services. So we saw a much higher number of individuals make that first visit. And then we are also getting more appropriate dosing because patients take the time online to fill out their full clinical survey when they first come to see us. What we've seen in the past is that people have the anxiety that is produced by being in any waiting room, and that we are getting more comprehensive data. As Baby Scripts mentioned, we also get 40 times the amount of data that you would normally have in a face-to-face addiction setting. So we're already data rich as a platform. I think we're producing some of the most exciting data in addiction science because of that. Telemedicine first orientation, but in the context of COVID, we've seen that quality of that data improve. And then time to first appointment has increased dramatically. So we hold ourselves to a 72-hour standard by and large, but we've seen patients be able to get to us 42% quicker because of the ability to self-sign on and directly do virtual care. And then by and large, I just wanted to provide some high-level outcomes within the Medicaid population. So this is a study that we did of patients, 479 patients within Michigan and California who had been with us over the course of a year. And we saw within that population a breakdown of 49% men, 46.6% women. A large chunk of those individuals are in the frame of 30 to 39, which is in line with what we're seeing nationally with the opioid epidemic in terms of age of treatment. But only 20% of these patients are coming to us from rural zip codes. So I think one of the big learnings from our platform and from our work is that patients in urban settings like and need telehealth services for addiction care. Largely, this is because of the same reasons why they need it in any other low-income setting. They have limited access to transportation, oftentimes limited access to money to pay for other services, other things associated with that, childcare at home, lacking, and housing instability. So in the context of all of those pressures, having the ability to access us directly virtually has been a boon. And then what we're seeing by and large, these are 6-month statistics that go over what we saw in terms of retention in the program. Specifically, this focuses on our OUD program, where we work with patients who have opioid use disorder and provide medication-assisted treatment. And we measure retention within this program as length of stay. So this is the time that a patient is enrolled in our MAP program month over month. What's really important about this is that we know, as a broader fact, within the substance use disorder treatment center ecosystem, that the longer you can keep a patient in an episode of care, the more likely they are to not relapse. And so we are seeing extraordinarily high retention rates at month 6, 67% of our patients staying with us at month 6, which is, I think, unparalleled in the space and very exciting. It makes the case that the combination of MAT care and social services wrapped around that care makes a significant difference, which hasn't been proven out in the space before. And then in terms of adherence, we see patients getting adherent very quickly because of the harm reduction orientation, meeting them where they are, and then staying adherent very long periods of time. And again, that's because we're meeting them where they are. It isn't a immediate abstinence-oriented model where people are forced onto the wagon, and if they slip up at all, they're kicked out. And that has been extremely efficacious. In terms of who we work with, we partner by and large with health plans. We're very much a Medicaid first business. My co-founder and myself started this organization because we lost a lot of individuals that had less economic means than we ourselves did at the time that we got sober in the Detroit metro area. And it's very important to us to ensure that individuals in the safety net have access to addiction care. We know, for instance, that within the Detroit metro system, before we were able to cover Medicaid in Michigan, we had a backlog of over 4,000 patients that were interested in our services that were not able to access them through traditional community mental health means, which is something we should all be concerned about. We work with a variety of plans and other treatment center network providers where we're subcontracted to provide the full digital care, and they're providing more of a hub service. And we're increasingly covered across the country by both health plans in bundled rate preferred provider contracts, which are very simple to roll out and rolled out on a monthly basis. There's a mix of both commercial and Medicaid lives that we cover, but 8.8 Medicaid and Medicare lives covered in the platform today.